Good morning, everybody. First of all, I want to say thank you, Michael Kraus, for inviting me for this very nice eHealth conference. First of all, my title is Online Psychotherapies Addressing High-Risk Substance Use, as well, of course, as substance use disorder. Next, I want to say thank you to my team, because not everything that I will show in the next half an hour will be from my own, but of course I was in the lead, but many others were helping me. There are psychologists, there are ethnologists, there are programmers, and so on and so forth. And it's also important to me to mention my declaration of interest. So every funding that I received that are ending finally in the slides I will show you next is highly competitive. So there is no pharmaceutical industry or anything else or alcohol industry behind this. A brief content overview. I will show it because I think it's really crucial that you know also what is happening in other mental health areas and not only in substance use, substance abuse area. Some insights, like what we could learn from it for the future also. Then I will go directly also in effectiveness questions for online addiction psychotherapy, for alcohol misuse, cannabis misuse, and illicit drug misuse, abuse. And for the sake of time, I will focus mainly on cannabis misuse, and also because there will be a workshop next to this. Finally, we will have a conclusion and also some take-home messages for you. I also learned over the years that it's important that we are talking about the same thing. And mainly these two first constructs or terms are important that you know it for following my speech today. It's about guided self-help. What does it mean? Guided self-help means self-help supported by an e-coach system and or professional counseling. So it's not only self-help, but some really crucial help from a support person. This can be an e-coach system, an e-coach video. I will show you some examples later, or professional counseling, like an extension of self-help with additional chat sessions. While blended treatment, and that's really the future term for this, what I will show you today, is talking and meaning a suitable combination of face-to-face and online therapy so that the disadvantages of one format can be compensated for by the advantages of the other one. And of course, vice versa. So it's about optimizing e-mental health with face-to-face mental health treatment. Then you have some acronyms like ICBT, standing for Internet or Mobile Device-Based Cognitive Behavioral Therapy, and the classical like substance use disorder, motivational interviewing, community reinforcement approach, and contingency management. So what we can learn from other areas. The question, of course, that arises in the recent years is there really a non-inferiority to face-to-face psychotherapy when we do online psychotherapy? And the first publication that narrowed this question was a meta-analysis that showed effectiveness similarities in social anxiety disorder, panic disorder, and depression patients in the sense of lowering depression symptoms from Gerhard Andreasson. And there are, in the meantime now, really non-inferiority studies investigating if guided ICBT is non-inferior for health anxiety symptom reduction. And this is mainly in hypochondrial patients, so those that feel that their bodies are having everywhere some illnesses. So this was really non-inferior to face-to-face therapy. Another area that is most important, I think, but it's not published so far, but I have seen the results at the presentation, is about the big European study where they compared blended, so really the optimization of face-to-face with online therapies or mobile therapies that wanted to investigate if it's not inferior to depression symptom reduction in major depression patients, and actually showed that it was superior than face-to-face troperidine. So this is the first study really, or there will be a couple of publications about these trials showing that can be really superior, this blended treatment instead of only face-to-face therapy. On the other hand, we know from a study 3 years ago investigating binge eating days, abstinence rates, and in eating disorder patients. And this one is showing that it was face-to-face in these patients was better than guided online self-help. So that's not inferior. So this was clearly better face-to-face when it's only about guided self-help. However, we do not know how it would be for blended treatment. Another thing that I think is important here from adherence in a meta-analysis for depression online versus face-to-face trials. So here up you see the face-to-face trials, and on the lower end there are the guided ICBT. And here you see that face-to-face leads can generally to higher retention, so adherence to going to the treatments or adherence to modules completion. And of course, in the substance abuse sector, you might know that adherence is really a key issue and really also a problem already in face-to-face treatment. So what about substance use disorder and online treatment? When you look at the spectrum that we could have from ever used to harmful use, misuse, abuse, when it really comes to consumption crisis and to rehabilitation, there can be online prevention, like peer review, school prevention programs that can be combined with online. There can be more when it goes to substance misuse, web-based counseling issues. So it can be relative counseling, medical assessment, and combined with web-based counseling. And today I'm going to talk more about also the web-based psychotherapies when it comes to outpatient treatment or inpatient treatment, how this could be combined or online from the beginning on when you go to the general population. So someone could go to the internet and have some assessments, and then it says, well, it should be better that you go to your psychiatrist or to your medical doctor and family doctor. You talk about them, about the results, and next, this can go directly, for instance, in this blended treatment. And of course, there is also the possibility of follow-up care. So if someone is completed his rehabilitation, this can be inpatient or outpatient, that there is a lower risk for relapse. So there are different modes of social distance. So from anonymity, where we have descriptive information, to this really narrow blended treatment where we also have to meet your patient face to face or your client. When we look what kind of study has been conducted so far, you see that exactly this blended treatment hasn't been investigated. Also Skype or Zoom therapy, so that what we actually really need now in this COVID crisis hasn't been investigated so far. There are some studies investigating chat counseling in addition to self-help, so these classical guided interventions. And most of the evidence that we have today in substance use disorder online trials is from online self-help, sometimes with guidance, and from this personalized feedback issue, so pre-screening and brief interventions. Regarding the domain of alcohol, so that's a meta-analysis from Helen Reaper from the University Amsterdam. You see right from the beginning that all these trials, is the zero, so the middle, you see all these in all these trials, on average, the intervention was more effective than the control condition. So that's a good issue. if you look in the details, there are some other issues you can find. For instance, that extended psychotherapeutic self-help is more effective than one-time personalized feedback. That's what one could assume that it is. However, so far there is no differentiation for therapeutic approach possible. So you cannot say ICBT is better in the alcohol field than other approaches so far. Although there are several studies with not always also ICBT involving. And what we know from the 2018 meta-analysis, that guided self-help is more effective than self-help alone. Moreover, we know that studies for controlled drinking show higher effects than those focuses on abstinence only. And what is surprisingly, and this also had some resistance for a long time in my colleagues that are only having face-to-face therapy, there are similar use reductions, so 5 standard units per week for harmful drinkers, and but also for heavy drinkers. Of course, the heavy drinkers, when they reduce for 5 standard units, you see that they still are drinking on high levels. However, when you look at pure effectiveness measures, then you can say it works also in heavy drinkers. And of course, also, it's urgently needed. There are no studies on blended alcohol treatments so far. And there is some little preliminary evidence from single studies that SMS or neurally also in smartphone-based aftercare that this is also possible and increases also the effectiveness in terms of reducing the relapse rates. What about the domain of cannabis? You see from the first view, this is also a result from a meta-analysis by Paris that he published in Drug and Alcohol Dependence Journal. You see that the situation is different. So there are also trials showing that there is no effects, and even some showing that the control condition was actually better than the active condition. However, in some, you see there is low effects, but there are on average effects. And if you look at some details, you see also that the effects are not maintained at longer term. So it's really about pre-post effectiveness. And when you look closer what happens to other causal reviews, then you see that also for face-to-face therapy interventions, there is not the possibility to show on average the longer term effects in the cannabis field. What we can see from this Paris meta-analysis that those combining cognitive behavioral therapy with motivational interviewing show higher effect sizes than one session interventions with, for instance, personalized normative feedback, only motivational interviewing, and brief interventions. The main limitations are there are so far mixed outcome measures, so there is no core outcome set for cannabis and no long-term follow-ups were measured. In the first Can Reduce study, when we started with online interventions, we wanted to know does professional chat-based guidance in addition to ICBT self-help have effects on internet intervention adherence and the cannabis use in cannabis misusers recruited from the general population. So does it have an additional effect as we know now from the alcohol field? This is how it looked like in the past. We have 8 modules based on cognitive behavioral therapy and motivational interview. And there is this small chat window where there was the possibility to chat with a therapist, so a professional psychologist, a medical doctor, or psychotherapist sometimes. What we did not expect actually was that the finding that compared with the Swiss outpatient addiction monitoring statistics, the ACT-INFO statistic, it shows that there were more daily users of cannabis than in the online intervention that those showing up for outpatient counseling, addiction counseling, which was quite surprising. So we meet a different target group online with more cannabis use frequency. When we look to adherence to cannabis diary, filling out the diary, we see that it was the chat intervention was a bit better in holding back the people, the participants in filling out the cannabis consumption diary. And after 3 months follow-up, you see that we have higher effects in the chat-based intervention, so the dark blue line, compared with the waiting list and the self-help only line. And this also became significant in the intention to treat analysis, where we see that self-help only with versus self-help plus chat was effective around 0.34 Cohen's d. But we questioned, of course, we asked ourselves, how could self-help not better be done? And from those in the chat intervention group, only 25 actually had a chat session. So it was difficult for them to get a chat session by the psychotherapists, by the medical doctors that offered them weekly possibilities for chat appointments. In the subgroup analysis, we saw that only knowing that there is a chat counselor who can be contacted increases effectiveness compared to self-help only. And of course, we also saw for the first time that depression and anxiety comorbidity was high. So what should be done about this? We should, of course, also address this and not only focus on cannabis use reduction. And we had some people that from the very beginning decided to abstain from cannabis. And actually this tool was programmed for people that want to reduce. So we had to do also something that we realized and learn from them, that they had an abstinence goal right from the beginning. So we designed Can Reduce 2.0. You see it looks different. This is adaptive also for smartphones. This is how it looked like in the German version. And we had this new idea of providing this e-coach and really recorded videos. So there's the each coach saying hello each time of a module. And there is also a dashboard where this e-coach, Lena, is always there, and you can write her as a participant a message if you have any problems. And she also says right when you log in, right at the beginning, for instance, it's time for the follow-up survey, please answer these questions, and so on and so forth. So there's always this contact with this e-coach Lena, and she also writes you back. But actually what happens is that only about 10% writes once in their intervention to the e-coach. And of course, there are many automatic emails, and at the moment there will be some follow-up issues, and she's writing all the time. For instance, you haven't logged in, can I help you? And things like this. Here's the link, just go back to the website or the module where you left the last time. Things like this. So it's about adherence, focus, guidance. There are, of course, consumption diaries. You see the modules are newer, and we also involved depression modules. So the module 3, meeting units, is about also behavioral activation. Tackle problems is about social problem learning skills, and for instance, how you could handle rumination problems or before you go to bed and things like this. So it's also about depression therapy. And then we have the voice of companion. So this is an addition. So these are fictive companions that will show up at critical points in the modules and telling the participants what in their situation helped them most, or what specific issues were important for them. And of course, you can change between these different profiles. What happens? Well, first, adherence went up. So it was better than offering professional chat counseling to having this e-coach issue. And you see, even after 4 weeks, there were still 1/3 following and logging in back and going up to the consumption diary and filling it out, of course. What about effectiveness? Well, you see, they are starting with about 25 days of cannabis use in the past 30 days, and it goes down in this version with this e-coach Deborah, goes down to 17 points, to 17 days. What also we tested in a second group is having a professional cannabis reduce group. So there is not only this e-coach, there is no photos in the second group, but there is this same adherence focus guidance with the reminder emails and so on and so forth, and the possibility to contact a whole can reduce team. And this is the waiting list control group, and you see there are clearly some differences. And actually we reached after 3 months follow-up Cohen's D effect sizes of 0.5, 0.67. So that's quite high. It's almost that high as the latest outpatient counseling study for cannabis users that stem from Germany. They have similar effects. Regarding the secondary outcomes, we found similar results for cannabis-dependent severity reduction and also for the reduction of general anxiety symptoms. So more effective reductions in general anxiety compared to the control group in the active interventions. However, depression symptoms decreased in all 3 groups, and PTSD symptoms, and that might be interesting questions to go into it in further studies, increased in all 3 groups. So cannabis use reduction means in daily cannabis user that PTSD symptoms might go up. And as we screened also for ADHD symptoms, we had a look at it, but we saw that having ADHD symptoms had no disadvantages in participation, and they showed similar effects despite the higher baseline use of cannabis and also of higher baseline use of illicit drugs. So saying that you do not want ADHD patients in online addiction therapy makes no sense so far. So if you have time once, please go to the Spanish version, canreduce.es, where you see a perfect example of a Spanish-speaking e-coach just at the front page. And actually, we are now also translating it into Canadian English and piloting CanReduce in Canada soon. However, it works in cannabis, it works in alcohol. What about illicit substances? So stimulants, mixed substance use, and opiate use. Well, we looked for the European Monitoring Center for Drugs Abuse and Drug Addiction. What kind of apps we try to make really a taxonomy and not only a review, what kind of apps are already offered when you look at the different app stores. And we look at the type of apps. You see there are some social media apps really functioning a bit like Facebook for those that have addiction problems, that they really share their opinions, their problems. And there are stays, for instance, where they remain consumption free. There are drug glossaries, there is personalized feedback. And there are mainly also self-help interventions, advice on consumption and harm reduction, and consumption logs as apps. In the settings, you see that many settings are covered, even adolescents, narcotics anonymous, MSM. What actually really was missing still is blended treatment. So apps that are designed for having face-to-face treatment with an app. So this is still missing also in the app stores. Regarding target groups, you see that we have covered many target groups already. However, most of this intervention and these apps were programmed by laymen. Sometimes you have to pay for it, and sometimes they're really unprofessional. So the first meta-analysis on online interventions and the effectiveness for illicit substances were divided for stimulants, so amphetamine, cocaine, for mixed substance uses. So there's mainly a hard drug in, but sometimes also mixed with ecstasy, cannabis, and alcohol use, for instance. And there are these really 4-5 studies in the opioid section. And what you can see that the studies so far are quite effective, with the exception of the stimulants. And there remains overall effects of 0.35, for instance. And there was, when you look a bit closer, a preliminary tendency that internet-based community reinforcement approach combined with contingency management was a bit better than ICBT. And what we did not really find in the cannabis trials meta-analysis so far, the interventions are also effective in the longer term. So longer term means here 6 months and more. Of course, the effects go down, but it's still significantly effective. Interventions for mixed substance users were 0.34, as you can see, and opioid users even a bit higher, but similar effective so far, which is quite astonishing. However, the meta-analysis shows also that the study format is of relevance. There was a significant higher effect for so-called add-on treatments. So, for instance, methadone maintenance treatments with an app, and those involving urine analysis. So this is also a methodological confounding. The main limitation so far is that there is a low variety for study countries. So many studies are stemming now from the US, and you know there are different health insurance issues than in many other countries. So we come back already to the conclusions and main home messages broken down now in the first slide for the substances. So in the field of alcohol misuse, internet-based counseling therapy is better than various brief intervention approach in alcohol misuses. However, there is a lack of clarity regarding psychotherapeutic approaches. In the cannabis misuse sector, it's ICBT is so far more effective in combination with motivation interviewing, and there are so far few studies on CRA and contingency management. In the field of amphetamine, coca misuse, you can say it seems to work, but there are severe adherence problems. There are more studies needed how we could really manage better these adherence problems. And it's really the area where it's really not working so far. However, as I just showed you, in the opioid mixed substance use sector, ICRA plus contingency management tends to be better than ICBT, but it's questionable about this feasibility, of course, in countries with functioning health insurance systems, where you cannot only just pay for having urine negative screenings. What we do not have is any results or studies about other therapeutic approaches. For instance, mindfulness-based psychotherapy in cannabis misuses, which makes sense to my experiences from face-to-face therapy, and what we actually are now trying out to compare it to ICBT online in the next Can Reduce 3.0 study. The take-home messages regarding treatment formats. Guided self-help on the internet works relatively well for cannabis misuse and with comparable effects actually as for alcohol misuse. There are no studies on blended therapy, cannabis and alcohol misuses or abuses so far, which is really a pity. Almost everything in app stores for the reduction of drug misuse is not checked for effectiveness. So in this taxonomy, it's not only many of them, of these apps are programmed by laymen, but all of them, and there were 67 actually in total, were not checked for effectiveness. While combined therapy in opioid and mixed substance misuses is likely being successful, for instance, OST with guided self-help or blended treatment. These are the next steps we should go with. And there are no studies in online aftercare in substance use disorder related to cannabis and illicit drugs. And of course, this could be easily programmed and developed. And we have some modules already from the alcohol field that should be used. And this should be also next studies urgently needed. So we are at the end. Thank you for your attention. And of course, there will be some possibilities to ask questions next. And there will be these workshops after the break. One that will be presented also on controlled cannabis use. Thank you for your attention.